Thanks, Amit, for your kind words of introduction. And I would like to really thank Dr. Wander for allowing me to talk on art and science of medicine. In fact, he called me up and he told me, Shashank, you need to talk on this topic. And I think I don't have any conflict of interest here, though I have a lot of support from the industry. I don't have any conflict of interest. And as Hippocrates said, wherever art of medicine is loved, there is also love for humanity. And we need to recognize the art of healing touch. We need to integrate humanity and humanities in medicine. We have forgotten the art of healing touch, which is very, very important because it protects you from many unseen and future problems. And we need to care. And it's a very important part of medical practice to be effective. And this is a slide I borrowed from our dean, immediate dean, Dr. K.K. Parikh, who spoke yesterday. But remember, we are all in the biological world in internal medicine. And variability is an inherent characteristic of biological world. Medicine is the art of probability and science of uncertainty. And we have based all this on the Gaussian curve or the normal curve at 95% confidence interval. So whatever we do, we are at 5% improbability. My good friend Dr. Muruganathan, who is now the dean, told me that if you really want to know art and science of medicine, heart, head and hand need to work in tandem. If the hand and head work, then you are a worker. And if the head is a thinker, heart is the intuition and hand is the worker, you need to know that some of them can make an artist, some of them make a technician, some of them make a philosopher. But we need to integrate art and science. Also remember that we need to have a sixth sense. It's really a fact that many of us need to recognize sixth sense. When I was the president of API in Ludhiana, when Dr. Wander was organizing as chairman, I started with the theme. You have all come here to listen. Whatever you listen, you just heard Dr. Atreja talking on apps. He is into swimming into a digital world. Okay, I don't even have an app on my phone. I just have an ordinary phone. I don't even have a smartphone. I use the phone just to speak if it's an emergency. But the newer generation has moved into this app medicine. And they have become victims of that. And they will be device addicted. You will have to have a device-free time soon. So what you listen, you need to learn. And what you learn, you adapt. And that is it. So what is this whole process of teaching and learning? It's interactive, it's complex, it's an organic process which is rational but emotional. And it's basically a process of learning and unlearning. You may learn something from me today, you may not learn something. So there's a learning cycle approach of insight, of action, of experience and reflection. So we need to learn. We need to take feedback. And then we get actively involved and feel safe. But we need to be, as clinicians, open-minded and motivated. We are all poor daily wage earners in India. Most of us are. Okay? And we need to be open-minded from the evidence and experience which we have got. But we need to make things that make clinical sense and time to reflect. Now, when you hear a lecture like this, you will only remember 5%. If you read a book, you will remember 10%. If you see an audiovisual presentation, 20%. If you see a demonstration of an act, 30%. If you go to a study group, 50%. If you try to emulate what others are doing, 75%. If you teach others, and I would recognize each one of you as a clinician should teach others. That is the best method to learn. And therefore, it is important that while pupils hardly learn anything, while teachers learn so much, and they are much wiser. So obviously our intention in patient care is to offer a framework for our learning process and learn a lot from the patients. Now remember one cardinal rule as a clinician. We cannot change you and you cannot change your patient. But we can develop a way of teaching or integrating art and science of medicine. And we need to motivate our patients. So obviously, I feel, as Brookfield said in 1990, teaching is an educational equivalent to white water rafting. And therefore, fasten your seat belts and let's get started on what is called as professional communication. Because really the art of medicine is professional communication, which is the first bit of my talk, which is the art of it. And my second bit of the talk is a science, using diabetes as an example, how it is ravaging us very quickly and fast. So obviously, chronic diseases have crippled us. And the psychology of any chronic disease is loss of control of body and health, change feeling about the body, and emotions and crisis reactions. Some of our patients are in denial, some of them are angry, some of them are very sorrow, some of them are very anxious, some of them have hope and anger both combined in ambivalence. And therefore, if you look at the psychological aspects, we have very different dependence on others. And we have different social relationships, whether it's job, work, or friends. And therefore, if you look at diabetes gives me a unique example because it's a never-ending story. When patients get diagnosed with diabetes, they are in a state of denial, then they react, then they handle, and possibly they have personal growth. At the Joslin Clinic in the US, people with diabetes live longer than the doctors because they are able to handle themselves better. They take care of their health better. And therefore, remember, patient is the center of our universe. It's an unknown country to be explored and conquered. And we as clinicians, if we really need to master the art and science of medicine, we need to explore and conquer our patients. Remember, if you want to be successful as a communicator, patient is our judge. He must feel welcome and safe. We must ensure that we are attentive, understand, allow him to express and make him understood. But we have a huge problem in medicine today. Our problem is we have a healthcare system and which is full of knowledge, full of recommendations which you are learning in this meeting, drugs, devices and services, including the apps which we are now listening to. And we have a patient system. And what is that patient system? Experiences, cognition, emotions, needs, values. And there's a big gap between the patient and the healthcare system today. We are trying to enforce our recommendations, our knowledge, whatever we are learning from the industry, whatever we are learning from our evidence base, and thrusting it on our patient system. And therefore, the best way, and we know that our healthcare system is very rational and logical when we see it from our window as a doctor. But remember, when we see the patient's emotional needs, often as doctors, we recognize it as irrational and illogical. And that may not be true. All the patient wants is holding the hand. My good friend Dr. Muruganathan was telling me, once he used a button to put in the mouth of a patient who was having pain while traveling. It was like a placebo, and he held his hand throughout the journey for 2 hours and the pain went away. So remember, it's important to recognize that we integrate our healthcare system, which is very rational and logical today, because of the science of medicine, to the experiences, cognition, emotions, needs and values, which we think are irrational and illogical. And therefore, the key cog in the two is communication. So the whole idea is we need to integrate the practice of medicine, which is diagnosing, treatment, medical care and devices, and we need to become a trusted motivator. We need to listen, we need to offer emotional support, we need to ensure that we cope our own emotions, which is annoyance, irritation, concern. Often I see if somebody wants to vent out, we get irritated, we get annoyed, sometimes we get concerned. We need to know that we have to be a trusted motivator without crossing the Lakshman Rekha. We also need to be an educator because there's an information overload. We need to give the right information, right instructions, demonstrate and evaluate. So the key word is not sympathy but empathy. If you want to stimulate patient motivation, challenge patient ideas, create a common platform of understanding and get into the mindset of the patient, we must communicate with empathy, and that is the art of medicine. So we need to have golden rules of communication, and I think we can do that. We need to understand that there should not be any misunderstanding between you and the patient, and we need to ensure that we have many lingua franca skills. Our signals, only 10% are words, voice is 35%, but the body language is 55%. Remember, whenever there is a stress between you and your patient, that disturbs communication skills. And that breaks that whole communication link. And therefore, we need to recognize that we have only one mouth. We need to use it judiciously. But if you use your 2 years better, I think you can go a long way in the art of medicine. Remember, communication is the most powerful tool. It's free of charge, practiced by everybody, and it's hard to change, but has serious side effects. If you do the right communication, you can be successful. If you have the wrong communication, it could be completely disastrous. And therefore, remember that it may be trained every minute, but art is on communication. What are the levels of communication? Physical environment. We need to have a right conducive environment, which is clean, and clarify the agenda when you communicate. We need to have content, but unfortunately we are in a Google day. Half the time we are device addicted. We have information overload, which is completely non-evidence based. And we have to deal with that, with the facts, and separate the facts from emotions, and that is the content. Then of course interaction. We need to be an active listener. We are very impatient because we see too many patients. And we need to ask questions as well. Voice, our articulation, speed of talk is very important. Sometimes I talk very fast. But remember, when you talk to a patient, sometimes you have to be slowly. It's important to articulate it right. Then, of course, body language. It's so important to give the right facial expressions. Talk eye to eye. Use the right position. Sometimes just hold a hand. Maybe it makes all the difference in your communication skills. So obviously the setting, dialogue, the facts and emotion separation, interaction, slow and clear pauses, expressing interest, right eye contact, not too much, not too little, expressing smiling, nodding your head is very important to improve communication skills. And therefore we should have good questions. So from a philosopher standpoint, if you have to be a teacher or an expert, we need to be a learner. And education begins with us by learning from the learner, from exploring what he has understood. And remember, every patient is different, independent of the disease you are dealing with, and he teaches us a lot. Now this was the art of medicine, and we need to communicate better. And we have been failing in that job to a great extent because of brevity of time. And time management is a skill, it's an art which we need to recognize better. Let me give you a very quick glimpse of evidence base of science of diabetes as we evolve this epidemic. Epidemics appear, they disappear without traces. Whenever a new culture period has started, like leprosy or English sweat, it came, it went. Remember, every epidemic like diabetes or hypertension is a history of disturbance in human culture, is what Furkow said in 1870. And therefore, when human and health transitions occur, for millions of years, we have issues like diversity and environment and economic interactions. But remember, we need to be very, very optimistic. Because the single greatest achievement in modern world is reduction of death rates. Everywhere. Across India, across the world. There is a substantial increase in the proportion of world's inhabitants who really feel well most of the time. And it's wellness what we need to recognize. If you look at the birth rate, death rate, and if you look at the demographic dividend, very clear that we have definitely done better. Unfortunately, we have moved the gear from communicable diseases and injuries into a non-communicable epidemic. And therefore, if you look at a Sambaru tribe, diabetes is only 0.1%. If you look at a white Caucasian, it's around 5%. If you look at India and China, it's 10 to 20% because of human migration. Asian migration in the last 200 years, the mitochondria is preserved, but we have migrated and changed. And we as Indians are thin and fat. So we are sarcopenic, we have abdominal obesity, we are sedentary and affluent. What is happening? We have ensured that our genes have adapted to population in a changing environment. We may have thrifty gene, or an out of Africa migration and metabolic adaptation to climatic stresses. Look at this. If you are a Siberian, and if you migrate elsewhere, if you are an Aborigine, if you are a Yagan, if you are a Pima Indian, if you are a Canadian Inuit, you see hot climate, cold adapted, heat adapted, resting metabolic rate, and obesity and cardiometabolic disease had changed. What else had changed? Food. Culprit food, cheap calories and processing. Fats, fructose, portion size, affordability, availability, and social gradient has actually given us the bomb of the whole non-communicable disease epidemic. And you can see that WHO now recognizes sugar is the next tobacco. And it's all the energy-dense foods which have gone up. And it's the refined grains, as my good friend Dr. Mohan has published, that has gone the odds ratio in our situation. And we have seen that it's not just a South Indian phenomenon. We did our START study, which showed that across India we eat too much of carbs, too much of fats, too little proteins. And that is really exploding the diabetic epidemic. The other problem is we are very inactive. We are sitting on chairs here, and we see either our smartphones or our idiot boxes. If there's a single intervention which you can do as a clinician, whether it is your house or outside in your patient's, take that idiot box and throw it out and have a device-free time for 2 hours every day, your quality of life will improve. You don't need any app. You really need to be physically active. Because we have recognized that it is not exercise, but even the NEAT, non-exercise activity thermogenesis, which is equally important. And that has been a big problem. We have become chair-bound individuals. We are not agrarian anymore. And if you look at typically the problem in India, the agrarian Indian had a NEAT of 2000. And a sedentary Indian has dropped it down to 700. And the other problem which we are seeing is we have changed our chronobiology. Now we have harsh winter months, food availability is low, so typically we are insulin resistant. And we are fixed in that wintering mode or insulin resistant mode. And when it's summer, we are glucose tolerant. So what has happened? We have in a dopaminergic state, hibernated, migrated, and wintered. We have become successful, goal-oriented, socially successful people, but we have a dopaminergic mindset. We have become sick society and sick people, though we are socially successful. That's all because of the dopamine in our circadian rhythm, because we are not sleeping appropriately. We are not sleeping on time. We are not sleeping adequately. We are not happy. And it's all in the master clock of our hypothalamus. It's all required in the dopamine receptors. We have evidence based to that. I'm slipping through the slides because I want to talk about this slide. We have become immobile. We have screen time, car time, and we have sleep deprived. We have chronic short sleep, which has huge consequences on health. And this creeping sleep loss is actually, the short sleepers have huge obesity and type 2 diabetes problems. So if you look at my last bit, it is the prevention of diabetes, because that is what I deal with. And when I have to talk of science of medicine, diabetes, we have got fast foods. Even in this auditorium, you are eating fast foods, which is fried, caloric dense, full of oil butters, lack of fiber. And we have embraced cola culture. We need to go back to our grandma's diets. We need to get the macronutrients right. We have too much of carbs, too little proteins, too much of invisible fats, and we are fibropenic. We need to eat less. We need to go back to nature. We need to encourage physical activity, whether it's yoga, whether it's smiling, whether it's physical walking, whether it's activity. I see a lot of people get up. They don't walk up to the mic to ask a question, and that's sad. We need to de-stress. We need to smile. We need to eat less and on time. We need to walk more. We need to listen to music. We need to monitor our waist, weight, glucose, and lipids. We need to cook in less oil. We need to go back to nature. And therefore, my prevention mantra was very simple. Eat less, eat on time, eat right, walk more, sleep well and sleep on time, and smile. And if you can do that, you can go a long way. Because we are in best of times, but we are in worst of times. Because we are in times of plenty in India, but our body engines are running in a famine mode. And we need to be having the right way to stem epidemics like diabetes. So what I have done are two things. First part is the art of medicine. Listen to your patient. Hear him out. Communicate with empathy. And second is whatever you learn, adapt it into your day-to-day practice. If you cannot adapt what you listen and learn, I think we will never be able to integrate the art and science of medicine.